So I'm a nephrologist. I'm a professor of medicine pediatrics and the vice president for research, education, and innovation at Women's College Hospital. In fact, I trained in the United States. I was there for almost 20 years, and I moved back to Canada in 2008. And one of the reasons I wanted to move back was really, it was interesting to see the differences in healthcare. And there are things that I think we can do in Canada, and hopefully we can do it so much better. So I'm going to try and go through the slides. If you don't know this already, chronic kidney disease is really common. We think there are 850 million people in the world that have kidney disease. And one of the things that's really important to recognize is that once you have advanced kidney disease, so very low kidney function or on dialysis or transplant, that there's a huge risk of cardiovascular disease, there's a huge risk of other morbidities that can happen, and then mortality. And so our goal as nephrologists is to make sure that we can screen for kidney disease and screen the high-risk populations for kidney disease. We also know that when you have low kidney function, so this is called estimated glomerular filtration, I'll talk about this a lot. Let's pretend you have 100% kidney function, and as you go down and you're about 50% kidney function here on the left, you will then progress to end-stage renal disease. So here's on the left, you're going to progress to end-stage renal disease. And then on this graph, this is the risk for overall mortality. And you can see that if you have a very low kidney function, that your risk of mortality is high. And as your kidney function improves to about 75 or 90%, let's say, your kidney function is still impaired, but you do okay in terms of mortality rate overall. This depends on how much protein you have in your urine, but definitely when you're up higher, you definitely have, you reach what we would call no higher risk. And the risk is similar when you take a look at those who've got cardiovascular disease and death from cardiovascular disease. So this is why we get so nervous when we talk about kidney function. And we're trying to understand this range of kidney function and see if we can identify patients a little bit sooner. So because the burden is so high, we really think that screening for kidney disease improves diagnosis, treatment, especially in persons with heart disease, diabetes, or hypertension, or in actually persons like yourselves who may have had a liver transplant, a heart transplant, or another organ. The risk of kidney disease is quite high, and so it's really important that we can screen those who are at risk for progressive disease, that we have a test that's easy to do because we have to do it multiple times. That's not that expensive because we can then do it multiple times. And that importantly, that it's an accurate test, it's reliable, and it's reproducible. You've been using serum creatinine probably for 40, 50 years to measure kidney function. It's not a perfect test. It only goes up when the kidney function is very poor. It's affected by sex, height, muscle mass, medications, and in fact, different lab assays would measure creatinine differently. So many equations in the 1980s and 1990s were developed to calculate kidney function to account for all these variations. In early 2000, while I was at Hopkins, colleagues at Hopkins actually classified kidney disease by generating this estimated glomerular filtration rate, the eGFR. And that was key to start screening. So they generated this equation using data that was available, which I'll go into in a bit. But what was great was it provided a number. So I used that number of a percent, but it provides a number so that it was clear to me as the physician, to you as the patient, to other people as care providers. When you have this number, you can say, okay, when it's very low, this is what you need to do. When it's okay, this is what you need to do. So it's easier to direct to care pathways. My colleagues also went and standardized creatinine measurements across the world to say, if we're going to measure this, it has to be done exactly the same way across the world. And by having the standardized reporting now, the labs were actually able to generate on the form, this is what your kidney function is, your eGFR, based on your serum creatinine. So similar to your cholesterol and your lipid profile, it would say, hey, this is the number that we get. You need to be aware of that. And then we were able to potentially look at outcomes for treatment trials and use kidney function as an estimate, which was important for us to be able to get treatments for kidney patients. This was a study called the African American Study of Kidney Disease that actually started while I was a resident in the 1990s. And in fact, the first 3 years were completed probably by 95, 96. And this study was done, funded by the NIH, to actually show that blood pressure control in those patients who are African American, who had an elevated creatinine, so had impaired kidney function, that in fact, using a specific medication called an ACE inhibitor, you could actually have control of that blood pressure and you would do much better. And so they were able to show in this trial that if you had very intensive blood pressure control compared to those who had standard blood pressure control in the trial, that in fact, there was a big difference in terms of how patients did. And so this was really important because it made sure it highlighted the differences in terms of kidney function over time and really taught us that controlling blood pressure is one of the single most important things that we can do in patients. And in particular, it was important to do the study among African Americans because to this day, there remains data, or at least in textbooks, that those who are of African ancestry may not respond well to ACE inhibitors, which is clearly not true based on this trial. And this trial was published in the 1990s, and subsequent studies up until 2010 and over 10 years follow-up still show that intensive blood pressure control is important and the type of medication that you get is important. And the reason I bring this study up is really just to show you that in fact, this was the study that was used to generate that eGFR equation that accounted for race. So there was data in this study among African Americans. They were able to take the calculated eGFR using serum creatinine and compare it to the gold standard of nuclear GFR. There were very few studies available with this gold standard GFR. There was one study called the MDRD, and then there was the ASK study, and then there was one other study that was done in polycystic kidney disease patients. And those were the only studies that were done. So because there was a study that specifically recruited African Americans, they then generated a race-adjusted eGFR because combining the different study populations and accounting for a difference in factors that may impact serum. And since that time, the rationale has been expanded to say, well, there may be potential differences in muscle mass based on limited studies. And so this was the rationale to use it at that point. But I think the issue is that the study then, it actually became incorporated into everything that we did. So we went from having an equation that was developed for research, and now suddenly we're using it everywhere. And it continued to be adapted and updated. And now there was this large collaboration called the CKD-EPI equation out of Hopkins that then started recruiting millions of different data sets from all over the world on over 1 million people. And was able to show that estimated GFR using this equation was actually predictive of morbidity and mortality. And it was just universally accepted that this was the way to do it. And yet it continued to have this adjustment for Black race, even though patients were now being recruited worldwide into the study with different data sets being merged together. And so the adjustment for Black race actually resulted in an upward correction. So if I measured the same measurement in the same person, and for this serum creatinine, for their age, and this is what I got in my estimated GFR, if I added that somebody was Black, they would actually get a higher measurement of what their kidney function was. So in terms of that percentage, it would go up by, let's say, 3%. But that resulted in Black patients having a higher eGFR, and therefore they were not referred for kidney disease evaluation or potentially referred for dialysis or transplantation. But because it was higher, they might have had access to newer medications for cardiovascular disease or diabetes that aren't given to patients with lower kidney function. So what's important is that we've really recognized, and this has been a reckoning over the last 2 years, of these health inequities that have been persistent within kidney disease. And what's really important is that a number of these factors are really important to understand what contributes to the incidence of kidney disease, and that race alone is not something that we should be taking a look at. And I just want to show you something that, in fact, what's happened is that as we advance health equity and how as physicians we're conceptualizing things, what we did was, in the past, when we take a look at basic or translational studies and you include race, you're inferring that there's a biological difference by race. And so it's really important for people to recognize that that's what really led to all this racial health inequities, and that there was this presumption that it was related to muscle mass differences, which in fact have subsequently been shown not to be true. And so what we need to recognize is that we need to be race conscious that we're understanding it as a social and power construct, and we're not thinking of it as a biological test. And so that's really important. And I think that's where, for kidney disease specifically, when we take a look at the eGFR, we have to consider those factors. What's also important is that language has changed over time, and how we used to use self-ascribed race in the United States is definitely not the same way that you would use it in other places, and not how we think about ethnicity or ancestry. And so for the work I do, is I try very much to have people describe their ethnicity, and I work on ancestry. But I think we have to think about self-ascribed race as very specific, and we have to stop people from using it to explain a physiological difference when it's a social construct. And so what's happened is that Vanessa Grubbs is a nephrologist, and she's written a lot about this idea of structural racism in nephrology, because we continue to conflate genetic ancestry with race, when in fact they're two separate issues. And so this downstream consequences of almost 20 years of using a race-based adjusted kidney function was really that physiological differences differ by race, a social construct, flatly wrong. We should use a research-derived equation initially, and then we use it for screening larger populations clinically, and it just balloons when we now make it generalizable, and we're now using the clinical realm, not a research realm, and basically it then took on clinical implications that people hadn't thought about. And it actually led to structural barriers for patients to obtain screening, delays in diagnosis, and referrals to appropriate care. What was remarkable was during the pandemic and even before the incident with George Floyd, that advocacy by medical students throughout the United States, actually in 2020, was just remarkable, in that they started saying, why are there all these race-related physiological differences, not just in kidney disease, but in lung measurements, in measurements for pregnancy, and when they should go and get a vaginal delivery versus a C-section. And there were all these times that through medical care, that basically physiological differences were now attributed to race, and that really shouldn't happen. And the medical students were great in advocating for it and really pushed it, and that really has led to a lot of these changes. I'm only showing this article in 2021, but just know that it started well before that. And I really give credit to all the medical students across the US who really pushed this wholeheartedly. We published our work, and this is what Charles was talking about. So elimination of race in estimates of kidney function to provide unbiased clinical management in Canada. And we are going to come up with some guideline recommendations that'll be coming out soon too. So what's important to recognize is that eGFR reporting, once it happened in the States, it also started happening in Canada. And what we did recognize was that adoption of that eGFR reporting in Ontario and British Columbia actually led to a 2 to 6% increase in use of medications that slow the progression of chronic kidney disease. So that was fabulous. So eGFR reporting is helpful because it takes away the math that's needed to calculate what percent kidney function you have, and allows them for physicians to look at the number and say, hey, you need to go see somebody, or hey, I should be measuring your blood pressure more strictly and providing more medications and getting that under control. Rates of referral also rose to 24%, which meant 23 new consults per nephrologist per year in Ontario. So it definitely made everybody much, much busier, but it was really important because it raised awareness of kidney disease for both patients and providers. But the issue is then we have a pathway that actually uses these numbers within Canada. This is our consensus guideline about the CKD pathway, in that you get referred to a nephrologist when you have an eGFR less than 30. You get referred to a multidisciplinary clinic when your eGFR is less than 15, and we're getting you ready for dialysis or transplant. And then you get referral for kidney transplant. And so there are 3 time points that we think are really essential to make sure that patients who are Black are really being screened appropriately, and that you have to remember that if you're overestimating the kidney function, you may not be as low as you really are in truth. And so then how can we make sure that you aren't getting delayed in any diagnosis? And when we actually had a session, and it's taken us a while, from in the fall of 2020, immediately the Ontario Renal Network Controlling Gift of Life in 2020 stopped the use of race-corrected estimates of kidney function, and since 2020 has not been using them at all. But it's important to recognize that we still have disparities in kidney disease. And in the United States, we know for sure that, in fact, the prevalence ratio between those who are African-American compared to those who are white are 4.2 in the mid-2000s. And it's gotten a little bit better. It was 3.8 and now 3.4. So it's gotten a little bit better in terms of differences. However, there still continues to be a striking difference. And so we need to make sure that persons who are Black are really getting screened much, much earlier on, and we want to make sure we prevent them going on to dialysis. I just remind you again, is once we know you've got kidney disease, we want to treat you with the best medications. And this trial showed us that patients should receive ACE inhibitors. And so we have to also get this out of the textbooks because it still continues to be there. And for some reason, patients always don't get optimal blood pressure therapy. We also know that there was this story about Jordan Crowley who was mixed descent, and because he was mixed descent, they applied the Black race correction eGFR. His GFR was higher, and he wasn't referred for transplantation, which when you read the story, you just think this is crazy. I can't even believe it's still happening. And so it was a story again about delaying treatment and how we need to make sure that this doesn't happen. And in fact, this was recently in the news, which in fact, some Black men in prison were not allowed to also have access to kidney care. And this was just based on their eGFR. And so a judge made a judgment based on some nurses who had also reported about using eGFR. And again, biased information that didn't get communicated, despite the fact that it's been in all the news, it was still not evident to the nurses or the judge that in fact they shouldn't have been using that equation. So downstream consequences are really important to think about. And this has taught me that, you know, we were using it initially as we started because that was the population that was studied, but there was no consistent review of it to make sure that we weren't doing something that really had unintended consequences. And so this was important because Charles really spoke about how important it was every time he gets his test done, and really thinking about how we should not be actually adding these barriers to care. What we should be doing is removing those barriers and making it easy for people to actually get screened for kidney disease. Because once you're screened for kidney disease, you can get diagnosed with having kidney disease, then we can manage you, treat you, and hopefully now with newer drugs, which are amazing, that have just come available in the last year or two, hopefully we can actually prevent people going on to end-stage kidney disease. Are there other tests of kidney function? And there are. Cystatin C is now a standardized test available at most laboratories in high-income countries. Using cystatin C and creatinine together is even more precise. Cost and widespread implementation has been challenging. And then the urine protein albumin measurements are also important. And so it's important that you get both your blood work done as well as your urine tested. And it's important because this is how we classify, taking a look at the figure on the right, and I'm just going to point here, but this is when this is your percent kidney function, let's say your eGFR. We're most concerned when we're seeing patients down here, but when we want people to be screened here, so when you're with the family physician or you're being screened early on, you actually are able to have treatment, and we're able to hopefully actually try and diagnose your kidney disease and prevent you from progressing on to where it's red. So when they actually did a recent study taking a look at race-corrected eGFR versus not race-corrected, that the difference was only 3 mils per minute. But it's important to recognize that if you were here versus here, or here versus here, this means you could have mild disease, or you could have moderate disease, or you could have moderate disease, or you could have really advanced disease. And so even though it seems like a small difference to people, it's really important to recognize that because people took this as the absolute truth, this number, without doing repeated tests to make sure people were really at that percent kidney function, what they've done is that they might have actually not referred them, but never assessed them again, or didn't assess them in real time. And that's really where these biases have the potential to really impact outcomes. And then the other thing is that in those who are potentially borderline, but could actually truly be higher, it's really important that repeat testing happens so that we can make sure patients get the medications and access to all these newer medications. So what can we do in Canada? Well, we think widespread implementation of eGFR that omits race would be an important first step to equitable delivery of kidney care for Black persons. And I think what's really important is that we did the CMAJ article to come out. The Canadian Society of Nephrology is also going to come out with a guideline, hopefully. We're trying to finalize it now. Alana James and Patricia Ocampo are doing webinars across the country to really keep bringing this back to people's focus. We're working with laboratories to change the reporting. And what's important is that UHN, for example, has now changed the reporting, which is great. We think cystatin C should be available, and we're trying to advocate for that. And then really we need to educate patient and physicians on who should be screened and how they should be screened, because it's absolutely critical. And that's it. I'm available for questions. I went through a lot of information very quickly, so I'm happy to answer any questions that you may have.
I had a question about, you said that it's important to get your blood work and a urinalysis done. I've been doing blood work forever, and it just depends on who gets me the requisition first, either the kidney side or the heart side, whether or not I get a urinalysis done. But, you know, any team just said you need to get this done now. So when I go back again, that will be done. What do you miss when you just do one or the other?
So what we've recognized is, and it's interesting that if the cardiologist doesn't do the urine test, is that protein in your urine can indicate different types of kidney disease. And so we know that when your protein is very high and your kidney function may be mid-level or getting lower, that you might progress faster. So it may make us adjust your medication and treat and make sure you're on different types of medication, or treat your blood pressure, even get stricter blood pressure control, because that can reduce the amount of protein in your urine. Your kidney doesn't like to process all that protein. And so if it spills it into the urine, it's just dealing with too much protein and it can't handle it over time. So it scars the tissue even faster. And so we're trying to prevent scarring of the kidney. So we really want to try to minimize the protein.
All right, that makes a lot of sense. Thank you very much.
And that's why people should have both tests done. And especially if you're diabetic, have heart disease, a previous organ transplant, any kind of organ transplant, and high blood pressure. We want people to be checking that on a regular basis. Yeah.
Some great information inside the presentation there. Thank you.
Yeah.
Hi everyone. I don't want to.
Oh, go ahead.
Sorry, I didn't want to talk over anybody. I can't see. I'm just logging on. Yeah, I agree. It's a lot of good information kind of on the history of where we've come and what we're doing now. I was curious of your opinion of why it took so long for these changes to be incorporated. I know you said that, you know, these were universally accepted, but there were students and scholars who were saying this from before, like some of the examples you used of why like race-based pharmaceuticals or other things were flawed. Why do you think, especially like in the Canadian context, it was so resistant to changing this, like that this took so long and impacted so many people's lives in the meantime?
I think because people were conflating physiological differences with potential biological differences that may be found in certain diseases. For example, I discovered the APOL1 gene, like the locus, the chromosomal locus that was associated with kidney disease. And we were studying it among those of African ancestry. And it was a very specific genetic question to then understand the biology of disease. And I think what people did was they were conflating all of that potential biological differences to suddenly a physiological test. And I think that's the part where we just really need to be clear about that, you know, and I think that people hadn't been clear about that. And I know when that eGFR equation got started, and it was the merging of those cohort studies together. And I think just subsequently, people didn't ask. Like, and it was so interesting to me because when I moved to Canada, I actually was used to asking people, how do you identify race for studies so that we could analyze it as a social construct to see if there were differences that we needed to be aware of. And what was interesting was people said to me that we don't measure race in Canada. We don't have those problems like the US. And I said, okay. And I then came back and I said, hold on, but you're collecting data on race in the Ontario Renal Network. And when I was on service one day, one of the nurses turned to somebody and said, hey, what race is that person? And somebody's like, I don't know. And so they were like, oh, well, what do you think? Like, and I was like, appalled. And I just said, that is not how you do this. This is not how it should be done. And I actually spoke to people back at the Ontario Renal Network and I said, any race data that you're collecting is completely wrong because it's not self-identified. And you can't have arbitrarily a nurse, a medical student, and a resident deciding race based on last name, based on what? Like, what is it based on? And it then became more obvious that they were using it, again, not as a social construct, but as potentially a biological, that there were differences, or kidney disease was higher. And I was like, yeah, but you have to understand what are the disparities that lead to kidney disease. And so it really is this whole discussion and pushing people to do it. And I think, you know, if we can think of anything good happening from the pandemic, it's like finally people are more aware and finally people are discussing these inequities and people are saying, you know, this is wrong, right? And so that's really important. And we just have to keep that momentum going, because I think there's a lot of education that we still need to do. And we have to truly eradicate all these other measures that include race, pulmonary function tests, like there's a number of them. Luckily, there's not a huge number, but there's enough of them that we need to keep the pressure on to get it done. What we need to do now, I know what we've done in Ontario and we're trying to push, but we need to really push nationally to say to every transplant procurement center, every place that's actually doing a transplant referral, dialysis, chronic kidney disease, making sure that they have all their metrics changed, making sure that they do local education, make sure all the laboratories have changed and changed their reporting. So part of it is you can do it nationally, you can do it locally, and we kind of need to do it every way, which way we can to make sure that the message gets through.
And I think, you know, that's again, I appreciate what you and some of your colleagues are doing here. I think, you know, to encourage in this group, what I always look to, you know, I'm hearing you say like people didn't know, but people within community did. Like I was actually at school in the area you were in around the same time. I'm a little older than I look. And I know that my professors had highlighted this, like we were at Howard and we had been speaking about it and challenging like some of the data coming out of Hopkins and other places. And so I think it's also important for us in this conversation to say that like, we need to include other researchers who have been questioning this and did know this, and it just wasn't part of the mainstream. So when we say it wasn't universally accepted, it was within community, people knew that something was wrong or something was off, but it wasn't accepted in other communities who were just like, no, this obviously there's a, you know, a genetic difference in Black people. And so I, you know, when I'm hearing you, it's also a lesson of how do we advocate, especially in this group, to say, you know, even if it's said, well, there's studies or this is clinical, how do we challenge that or include that, we ensure we're included in the research, in the conversations, or varied researchers who were considering these factors so that going forward, we can also challenge and ensure it's not happening going forward, as you said, right? How do we now challenge this on a national level?
Yeah. You know, it's so interesting because people said to me, you were at Hopkins, like, how did you let this happen? And I said, you know, when we were doing it, I was taking care primarily of children, and in children, we had a kidney function measure that never included race. And I used to say to them, how come in children there's no race adjustment, but suddenly there's no race adjustment when you become a teen? Like, that's so crazy. But what's interesting was we had a group of nephrologists or physicians who were researchers who were Black, who didn't think it was a problem. And I think that's you need to have that breadth that you were talking about of people who see it from different angles to say, no, it is a problem. And these are the downstream things that you haven't thought about, right? And I think that's really important, right? And so I think that there was this unique view of one or two people, but that was clearly not the view of everybody. And it just became really obvious to me when I moved back how it shouldn't have been included, right? And it actually became more obvious when we were participating with larger studies. We couldn't do that race adjustment. So studies included some Canadians, didn't include others. And again, it became arbitrary. And I said, again, this is just wrong, right? So, but it's it's easier for us to do it as a group, then I can imagine how difficult it was for your professors to go and argue, you know, to some other professors at Hopkins and say, hey, this is wrong. It's almost like we need a community to come back and say, hey, this is clearly wrong, and we got to think about doing this differently. So. I think the other thing that I try to teach people now, and I've been teaching people for a long time, ever since I've worked on that genetic study, was in the States, there was always a way when you presented, and you would present that this is a, you know, this is a 64-year-old woman from Haiti, right? This is a 35-year-old woman from Baltimore, right? Like there was a way that we would describe it, and we would include race. And as a Canadian training in the States, I was like, why are we doing that? I don't understand. And it was really interesting because the reason for it again was just so entrenched in medical school training, right? About these differences. And I think I did a lot of rounds and visiting professorships since 2008. And I always say to them, why are you saying that? Like, know why you're saying it. If you're going to say it, know why you're saying it, and then make sure that you don't have an implicit bias and that you're now looking at things biased in some way. So I think it's getting those things that are entrenched in medical school training and entrenched in how we do things. It's a lot of work, and I think we really need to actively do it. So I think it's great medical students are doing it, because they can really push the medical schools to get it done faster. And it's great that they're advocates at a young age. So hopefully then they'll be advocates lifelong.
The future is brighter.
I think so. I think they're willing to speak up and challenge. And I think, again, it's probably because of numbers. And I think that's all good, right? We do have on the Canadian Society of Nephrology guidelines, and one of the pathologists who's involved in lab reporting. And so we're hoping that they're going to do a push from a national basis to basically eradicate it in the labs themselves. I've been trying to get that sort of out there so that people could do that. And you're reminding me again, I'll have to go back to Life Labs and go back to Dynacare to push them again. I don't know why they're taking so long, because they're also US-based companies, and in the US, they've definitely also advocated for change. I got a medical student from Ottawa who had emailed me after our paper and is sort of wanting to do these pulmonary function tests. I'm hoping at Women's College we can do a systematic review and then eliminate all of them at once. And so that's really the work Lana James is doing with Patricia Campo, is going from hospital to hospital to really identify them, get a champion within the hospital to try and show that you really just need to get rid of these. So there is a lot of work going on, but I think from a patient perspective, the more patients that step up and also say, hey, this is wrong, and really push both at a hospital level, a lab level, a community level, that's great. I think everybody needs to push.
I think it's important information, you know, especially for our community to get out there. And like you said, we can all be advocates for this, and it's going to take all of us to make the change. So thank you.